Postpartum hemorrhage. Background. Postpartum hemorrhage (PPH) is the leading cause of maternal mortality. All women who carry a pregnancy beyond 20 weeks gestation are at risk of PPH and its sequelae. Although maternal mortality rates have declined greatly in the developed world, PPH remains a leading cause of maternal mortality in many developing countries. The most recent maternal mortality ratio was estimated to be 281 per 100,000 live births in Nepal, about 25% of which has been attributed to the postpartum hemorrhage. Definition. The traditional definition of primary PPH is the loss of 500 ml or more of blood from the genital tract within 24 hours of the birth of a baby after vaginal delivery and loss of 1000 ml of blood from the genital tract after cesarean section. Types of PPH. Postpartum hemorrhage can be divided into two types. 1. Primary or early postpartum hemorrhage, which occurs within 24 hours of delivery. Secondary or late postpartum hemorrhage, which occurs after 24 hours to 12 weeks after delivery. Most cases of postpartum hemorrhage, greater than 99%, are early postpartum hemorrhage. What is primary PPH? The traditional definition of primary PPH is a loss of 500 ml of or more of blood from the genital tract within 24 hours of the birth of the baby. PPH can be minor, that is 500 to 1000 ml of blood loss, or major, that is more than 1000 ml of blood loss. What is secondary PPH? Secondary PPH occurs when there is abnormal or heavy vaginal bleeding after 24 hours to 12 weeks after the birth of the baby. 4 mnemonics for the specific causes of postpartum hemorrhage, that is 4 T's, which are the causes of postpartum hemorrhage. So, the first T is tone, and the specific cause is atonic uterus, and 70% of the causes of postpartum hemorrhage is due to atonic uterus. 20% is mainly due to trauma, that is the second T. So there can be lacerations in the vagina, in the cervix, there can be hematomas in the pelvis region, and there can be inversion of the uterus, or there can even be rupture of the uterus, which is another leading cause of postpartum hemorrhage. Third T is the tissue. Retained tissue and invasive placenta like placenta accreta or placenta prakrita, which is 10% of the incidence of postpartum hemorrhage. Then comes the fourth T, that is the thrombin, and the specific cause is the coagulopathies, and the incidence of which is only about 1%, and it's the least commonest cause of postpartum hemorrhage. Causes of secondary PPH. Most commonest cause of secondary PPH is infection. Infection inside the uterus or the infection of the endometrium, that is endometritis, is the most commonest cause of secondary PPH. It might be due to infection of the retained placental parts and the membranes, and this leads to the subinvolution of the placental site and also subinvolution of the uterus. Rarely, it can be trophoblastic diseases, or it can be pre-existing uterine lesions like submucosal uterine fibroid, and very rarely uterine arteriovenous malformation or inherited coagulation defects. Risk factors for different causes of postpartum hemorrhage. First one, the tone, which is the most commonest one, and the cause for uterine atony is multiparity. The uterus has already lost its tone because it has given birth to so many children. The elasticity is lost. Second thing is multiple pregnancy. The same principle holds here also, where the uterus is overtly enlarged. So, coming back to its pre-pregnant state is very difficult, and it's one of the most important cause for atonic PPH. Previous history of postpartum hemorrhage. If the patient is more than 40 years or if the BMI is more than 35, obese patients are more prone for uterine atony. If the labor has been prolonged or if there is placenta previa. The second cause is the trauma to the perineal region, or if there is a vaginal tear during the birth of the baby, if there is a cervical tear during the delivery, or it might be due to the cesarean delivery where there might have been an extension of the wound, or it can be instrumental vaginal delivery, which is the most commonest cause for cervical tears and even uterine rupture. Third is the tissue. So the first thing that comes to our mind when we talk about tissue is retained placenta, or it can be morbidly adherent placenta like placenta accreta or placenta percreta. There can even be abruptio placenta or placenta previa. Then thrombin. This is the least commonest cause of postpartum hemorrhage, and the risk factor for coagulopathies are congenital bleeding disorders, acquired coagulopathies if the patient is on anticoagulants, or if there is placental abruptio leading on to coagulopathy, preeclampsia, sepsis, and amniotic fluid embolism. These are the most common symptoms and signs of postpartum hemorrhage. Uncontrolled bleeding per vaginum. Sometimes bleeding can even be so mild, but it keeps on happening for a long period of time, leading to problems in the lady. There can be swelling and pain in the vagina and perineum bleeding. If bleeding is there from a hematoma, the patient can later have tachycardia, hypotension, and anemia. These are just the drawings where I wanted to show what are the common symptoms and signs of PPH. This one is uncontrolled bleeding per vaginum, leading on to hypotension, tachycardia, anemia, and then dizziness. The most important part of management of PPH is the prevention of postpartum hemorrhage itself. So we have to identify the different risk factors. I've already mentioned in my previous slide also, like multiparous, or if she has a multifetal pregnancy, previous history of postpartum hemorrhage, or if she has coagulopathies, if there is preeclampsia, all these things we have to identify, and then these are the ways to prevent PPH. Then the active management of third stage of labor, which includes controlled umbilical cord traction, administration of uterotonics like oxytocin, fundal massage, and also the most important thing is to remember to empty the bladder. Secondly, we have to assess for 40s of PPH. Then we know what is the cause for PPH. Like the most important thing, 70% of the time it's mostly due to atonic uterus. So we have to find out whether the uterus is well contracted or not. Secondly, we have to see after the delivery of the placenta whether all the membranes and all the cotyledons of the placenta are present or not. Then third is trauma. We have to see if there is cervical tear, or if there is vaginal tear, or if there is inversion of the uterus. Cervical tear and vaginal tear is important when we are doing assisted vaginal deliveries. Thirdly is thrombin or coagulopathy. This is we have to take a proper history and then ask the lady whether she had excessive bleeding when her tooth was removed, or she had swelling in her knees after a fall, or whether she bled profusely after a minor cut. So this is a way we have to assess for 40s. Then when a lady presents with postpartum hemorrhage, resuscitation is very important. So you need to have an obstetrician at the bedside, monitor the vital signs of the patient and the patient's status, call for help, and start two large bore IV access, and in the meantime send necessary lab work so that you don't need to prick the patient again. Administer oxygen and IV fluid resuscitation, and send the blood for blood group and RH typing, and also cross match at least 2 units of packed RBCs so that if a lady needs the blood, it is ready for transfusion. This is a slide which shows the different T's and how to manage each of them, and I will be talking each one in detail in subsequent slides. First one is a tone, which is the most commonest cause of PPH. That is 70% of the PPH is caused by uterine atony, and the treatment will be fundal massage. Here in the first picture, you see that bimanual massage is being given. Here, the examiner puts one hand inside the vagina and the other hand over the abdomen, and he or she is giving a bimanual massage to the uterus in order to compress and prevent uterine atony. Secondly, will be uterotonic medicines like oxytocin, Cytotec, which is a prostaglandin E1 derivative. It's given 1000 micrograms per rectally. We do not keep it per vaginally because the lady is already bleeding. It might get washed away. Methergine, which is an ergot derivative, we give 0.2 milligram intramuscularly. The other way to compress the bladder is also by applying a B-Lynch suture, in which a brace-like suture is placed over the uterus such that it is compressed. And the last picture is the picture of a buckree being inserted inside the uterus so that it compresses the uterus and prevents postpartum hemorrhage. Is the tissue, the recent placenta. It is the 10% of the cause of postpartum hemorrhage. So, we have to inspect placenta for the missing pieces and also the membranes after the delivery of the placenta. And we should do an ultrasound and see if there is retained bits of placenta. And then we should either go for manual removal of placenta if it is adherent, or go for DNC if there are missing cotyledons. Here we can see a picture of retained placenta. The umbilical cord is hanging down. The hand is being inserted and we have to follow along the umbilical cord, go inside the uterus and remove the placenta. The third commonest cause of PPH is trauma, and it can be simple lacerations to the vagina or to the cervix, or it can even be grave conditions like uterine rupture. So it is 20% of the cause of PPH. So we have to inspect for lacerations of vaginal tissue or cervix, especially after instrumental deliveries like after forceps delivery or after vacuum delivery. We should also inspect for inversion of the uterus. How do we inspect for the inversion of the uterus? When we do a perabdominal examination, we might feel a dimpling in the fundus of the uterus. It is one of the signs of inversion of the uterus. And if there is hematoma, there will be increased pain, the blood pressure might decrease and heart rate may increase, and the lady may not be able to pass urine. So, not being able to pass urine in the first hour post delivery is one of the signs to say that it might be a hematoma causing um, increased pain, and because of the pain, she might not be able to pass urine. If there is any of these, we need to repair the trauma and evacuate the hematoma. The first picture shows a cervical tear. Here we can see the apex. So, with the help of the ring forceps, we identify the cervical tear and then we suture when needed. Uterine inversion, here we can see the fundus of the uterus coming out through the vagina. Here we have to hold the uterus in a manner which is being held in the second picture, and then we push it up and keep it. We put our fist inside so that it does not invert again. Here in the third picture, we see a bluish discoloration in the pelvic region. This is the supralevator hematoma. It is not a very good thing, and the women might be hemodynamically unstable after this kind of hematoma. The fourth thing is a thrombin, and less than 1% of PPH is due to thrombin. So coagulopathies. Here we need to obtain complete blood count, prothrombin time, APTT and INR, and fibrinogen levels. We have to consider giving fresh frozen plasma of factor 7A and platelets if there is coagulopathies. Assess for history of hemophilia or von Willebrand's disease, ITP, TTP, or other bleeding disorders. Tranexamic acid can be given to promote clotting, and we should always rule out help when there is coagulopathy. Complications of PPH. First thing is hypovolemic shock, which can even lead to renal failure and, if unrecognized, can lead to multi-organ failure. There can be transfusion-related complications. There can be ARDS, acute respiratory distress syndrome. There can be infections and septicemia and venous thromboembolism. If the bleeding is very severe, there can be postpartum pituitary necrosis leading to Sheehan syndrome and anemia. And if this cannot be controlled, then there can even be very grave situation like maternal death. Thank you. Dhanyabad.